All
All right.
right.
Well, good afternoon, everyone. Thanks for joining us on the first full week back after a long holiday. I know it can be hard to work these kinds of things in, but we feel like these conversations are still like so important. And every time we talk about like new things. So we're pretty open and free. This is a conversation we say for over the next hour. And any questions you have, feel free to put them into the chat box and we will answer them kind of as we go. But I think that I'm going to go ahead and introduce myself first. My name is Dr. Melanie McKean. I am a reproductive psychiatrist. I have a private practice, McKean Reproductive Psychiatry in Chesterfield, and I specialize in seeing women of all ages, teens through postmenopausal for a variety of issues. A lot of it has to do with pregnancy and postpartum, but certainly see a lot of things having to do with menstrual issues, whether it's premenstrual dysphoric disorder. And certainly one thing that prompted us to start these monthly conversations is having a lot of women who have been with me through a lot who are now perimenopausal and having a lot of those questions, concerns. And so we have, for those of you that haven't joined us before, like we like to talk through things with our three different lenses, the mental health side of things, internal medicine, and gynecology. And so again, thanks all for joining. I'm going to toss it over to Dr. Lynn.
All right. So thanks, Melanie. I am Dr. Becky Lynn. I have a cold today, so I apologize for being stuffy. I am a gynecologist and a menopause specialist. So I am North American Menopause Society certified. It's now called the Menopause Society. So beyond residency, I went and did extra training on perimenopause, menopause, including hormones, but everything else that a perimenopausal and menopausal woman might need to maintain good health. I am also board certified in obesity medicine. So I help a lot of women lose the weight. Yeah, so I'm really excited to be here and just to talk about all things perimenopause and menopause.
Awesome. Thanks, ladies. And I'm Dr. Amy Loden Tiffany. I own a Vitality Medical Wellness Consulting here in St. Louis. Like Dr. Lynn, I also am certified by the Menopause Society and obesity medicine, board certified. I do a lot of lifestyle medicine, dabble in some functional medicine. So one of those people that always gets bored easily and needs something new to focus on, that would be me. My focus has continued to evolve over the past decade, and now we primarily work with women who are trying to optimize their bodies before pregnancy, after pregnancy, and through the menopause transition. It doesn't have to be just weight. It can be reversing insulin resistance, lowering cholesterol, getting off medications for blood pressure, all the stuff. So that's what we do. And I'm super excited to be here today because I had the prototypical experience this morning with one of my patients. And I don't have to text you, Dr. Lynn. I can just ask you and get your
Sure.
opinion on this. So I have a really lovely patient who's in her 50s, doing all the right things lifestyle medicine wise. She's physically active, she's getting good sleep, she's managing her stress, she's eating well. We tested her metabolic rate and she's been working really hard. And she's on hormones, has been for the last 2 years. It feels like she just can't lose the belly. And so, with our obesity medicine focus, of course, I could talk and go right into GLPs. But I'm kind of curious when you run into someone who they're on decent doses of hormones and they're not losing the belly
Mhm.
weight and they're doing all the things, talk
Mhm.
us through your thought process in helping someone like that really go to that next level because it's always those last 10 pounds, right? And it's always in
Yeah.
the belly.
Yeah, so that is the toughest thing, right? Like, someone who's doing everything right and still can't get rid of the belly. So, obviously in my practice, I never just hop to the GLPs. I talk all sorts about weight or not weight, about nutrition, what you're eating, how much protein, how many calories, how much fat, carbs, the whole deal. We have here two dietitians that do a ton of counseling for, good health and good dietary habits. We talk all about exercise and strength training and building muscle and all the benefits that has. Like you, I screen for insulin resistance. I screen for any underlying disorders that might be contributing. And the thing with hormones, so here's kind of where hormones play a role. So hormones are not weight loss medicines. They're just not. But they do sort of play a secondary role in weight. And they do that in a couple ways. So they do that by improving how well your insulin works. So some women, especially as they hit menopause, will develop insulin resistance. Where their insulin doesn't work well. So in order to get the glucose into the cells, their pancreas has to make a lot of insulin, and high levels of insulin make you deposit fat. It's an anabolic hormone. So estrogen can improve how well your insulin works, thereby lowering your insulin levels and secondarily helping with weight loss. But in and of itself, it doesn't affect your appetite. It's not going to boost your metabolism. So it secondarily works through improving how well your insulin works. The other thing it does is it does affect body composition, because when women get to this menopausal time, they start to deposit fat around their middle. And that's the kind of fat that we don't want, because you can have fat around your middle underneath your skin, that's subcutaneous fat, or it can be around your organs, and that's visceral fat. And that's the kind that's associated with bad metabolic outcomes, high cholesterol and hypertension and things like that. So being on estrogen helps your body composition, but it's not going to prevent belly fat. And, so when we get to this point, some of this is going to be genetic, right? Like some people are gonna deposit fat around their middle, and it is so, so very frustrating. So we wanna optimize anything and everything that we can. We also talk a lot about stress levels and ways to lower your stress levels. So your cortisol isn't so high. High cortisol makes you deposit fat. So we really just want to optimize everything we can. And sometimes women, this is, just what I see in my practice, they'll be thin. They'll be super thin, but they still have a little belly. And sometimes that has to do with pregnancies, right? Like that, you get a little belly, your belly was big and stretched out when you had babies. So, if they're at a point where they're otherwise a healthy weight and they're metabolically healthy and they want to do something about a problem area, then you could consider things like cool sculpting. And, because at that point, and cool sculpting is not going to get visceral fat, that's only subcutaneous fat. I can't remember if you said about the patient was on a GLP-1 or not.
She's not yet.
Yeah.
That was kind of our question is, should we go here? And she and I were talking through it. What she decided to do, like you, we have, instead of dietitians, we have lifestyle medicine nutritionists and coaches. And so she's going to work with them for 3 months and we're going to repeat labs. But it really got me thinking about, this is the prototypical experience that so many people have is they go in, they tell their nurse, their doctor, I'm doing everything. I'm doing all the things and I'm not getting those results. And so I was curious, what you were thinking there. And, in our practice, we talk a lot about intermittent fasting or restricted windows of time-based eating. We also do a lot, and this is kind of to Dr. McKean, like this is something I think you probably run into, is we screen everybody for binge eating disorder. And so because the GLPs are so expensive and they only work when you use them, right?
Yeah.
Sometimes that's not fixing the underlying problem. And so Dr. McKean, would you have any interest in walking us through your thoughts when it comes to binge eating disorder and how you deal with that, what it is, all those good things?
Yeah, for sure. I mean, I think anytime we have these conversations about weight and about eating patterns, my lens is always thinking about, also, disordered eating or eating disorders, and having to be careful, because somebody that has a pre-existing eating disorder can certainly have everything that both of you have been talking about and deserve to have that addressed and treated, and not blanketly saying like, oh, because you have a history of restrictive eating or you have a history of this, like we can't pursue that. But, you do have to be a lot more mindful about kind of like, what are the goals here? Why are they presenting to your office? Like, is it genuinely because of this is changing with perimenopause, or is it like a new development in a pre-existing or maybe potentially still active eating disorder? So, right, with, and it's always had been a concern of mine with people that were moving forward with surgical options having to do with weight, because definitely in those situations, and those require, hopefully generally, but not always, like a psychological evaluation to determine like intentions and making sure that people understand like what they would have to adhere to. I guess, one benefit of the movement towards these other medications is that it isn't like a life-threatening situation if somebody doesn't adhere to the caloric intake or size and that sort of thing, whereas people could have devastating outcomes previously. But
Yeah.
yes, I am always looking at like, is this binge eating disorder? Does it meet the criteria for that versus, again, genuinely like nothing's changed in how they're eating, nothing's changed in their exercise plan. Everything has just like settled itself differently, or they're gaining weight when they shouldn't have.
Yeah.
For those that don't know, like binge eating disorder is going to be like discrete episodes of like increased volumes of food. And a lot of people will kind of just kind of like with OCD, they kind of say, oh, I binge eat this or I binge eat that. And they kind of throw those words around, but it's significant caloric intake. It's not like, oh, I ate a little bit of extra pizza than I should have, or an extra slice of pie. Like it's sometimes people almost dissociate or don't even like remember what all they've eaten because they literally have like eaten several meals worth of food. And the way that differs from somebody that may have anorexia, binge purge type, or even bulimia is there isn't any compensatory action because of it. There isn't any inducing vomiting or using any sort of like pills or any other ways to compensate. It's just, again, more so just a lot of guilt, a lot of shame, a lot of hiding. And so, right, we do want to make sure that even if they initiate, whether it's FDA approved medicine for binge eating disorder and the only one that I really prescribe for it. But right, I do have some that are seeing me for one thing, and then I find out that they've seen somebody else and now they're on like Ozempic or Wegovy or Mounjaro, and I'm like, did you tell them about the also to make sure that everybody's on the same page? Because
Right.
the goal is for them to be losing weight, but if they're still acting on binge eating, that's going to get really, really complicated.
Yeah.
So one thing I did want to add, Dr. Loden, is yes, if you've tried everything, then the next step, in my opinion, is GLP-1s if you have weight to lose.
Yeah.
And then Dr. McKean, yeah, we definitely see some binge eating disorder, and I think it's so important to screen for. And one thing that I see in my patients, and I think this is part of it, is like that feeling of I cannot stop and I'm out of control. You
Mhm.
have no control over what you're eating. So thank goodness for people like you who can help patients with binge eating disorder, because
Yeah.
it's a problem. There is a lot of shame and guilt, and patients won't mention it, I find, unless you ask. Some will, but I find that a lot really don't unless you ask.
Well, and a lot
Well,
of them love this. Again, they say like turning off the food noise, which for some people
Yep.
is literally those binge eating voices in
Mm-hmm.
there. And I'm always asking them like, well, what's the plan? Have you talked about like what the plan is long term? Because this is helping you right now, but are you going to be taking this long term? What's going to happen when you wean off of it? Are you also meeting with, again, like a dietitianist or a health coach or somebody that's going to be helping you to instill those positive things? Because again, with binge eating disorder, that isn't something that just gets turned off.
right.
There has to be like a lot of other help along the way, especially once they wean off of these medications. If they wean
So
off. In some
wh-
cases,
If
they
they wean
aren't.
off, yeah. Because they
one of
don't
the
have to.
things,
There's nothing that says that you have to stop Ozempic for weight loss. And in fact, there's a lot of thought that you may need to stay on these long term to maintain your weight, because your body's just going to want to regain all that weight immediately.
I think that is a big misunderstanding with these meds. I have people come in all the time and say, I want to start this, I want to jumpstart my weight loss. And it does change your body mass, right? It does help with that, but it's not just helping you lose fat, you're actually losing muscle too. So if you don't have in place plans to build muscle, you're going to lose more than just fat mass. One of the things I've noticed is people who are on any of the GLPs for diabetes or weight loss, they often will say their food noise goes away. And that often clues me in retrospectively that, gee whiz, I should have been screening them for binge eating disorder, because now when they screen for it, they're screening negative because it's turned the food noise off. So I really appreciate what you're saying there about the importance of screening for that. And isn't it something I feel like I read recently, like 98% of women who have binge eating disorder don't know they have it. It's something extremely high, right, Dr. McKean?
Right. A lot of people don't. Again, some people think they have it and they don't. And then
Yeah,
the converse is definitely true. And I think it,
yeah,
it is one of those like really, really shameful sorts of things that
yeah.
people don't want to talk about because they've been hiding it with the people that they trust. Now, sometimes I'll find out that they, yes, are more comfortable talking to me about it than anybody else.
Mhm.
But you really have to get somebody to be comfortable with you, to talk about any sort of like intimate sorts of things or like shameful sorts of things. So it's just really establishing that rapport. And if somebody is coming in just with the intention of, like you said, kickstarting weight loss, like really getting into the heart of like what's driving that.
Exactly. And I get a sense that there's a number of women, I don't see this so much with my dudes, it's the women, who they'll just chalk up their eating patterns and behaviors, even though they have binge eating disorder, they'll chalk it up to emotional eating. I'm
Mhm.
angry, I'm tired, I'm frustrated, whatever, and they'll just call it emotional eating. And you really start
Mhm.
drilling into that more. And that's it, it may be in the context of emotions, but that's not what's provoking the binge.
Yeah.
And that it's an actual brain disorder, it has an actual treatment. I think people deserve to know that.
Yeah, I think the fact that there is treatment,
Mhm.
I don't think most people know that. And in fact, before I started doing obesity medicine, I didn't know there was an FDA approved product to treat binge eating disorder.
Yeah.
So, I feel like people think I just can't stop. It's me, it's my fault. It's all me. There's nothing I can do about it, which is just completely wrong.
Thankfully, it is something we can do something
Hopefully.
about.
Yeah.
So, well,
Yeah.
that was my interesting case this morning. I wanted to run by both of you and see what your thoughts were and pick your brains a little bit because, it's a little bit easy to get in our own niche specialties and then go down all the normal things we would do and forget that there's two other lenses here I should be thinking about. Uh,
Yeah.
so appreciate that insight from both of you.
So I have one little thing to add, a little tidbit that has to do with weight, and then we can turn more towards menopause or hormones if everybody wants. But I was listening to a podcast, and they were talking about how humans are the only mammals that have, a significant level of fat, percent body fat, compared to any other mammal. Most mammals have what's normal for most mammals is like 4 to 5%.
Mm.
But humans have evolved to be like 20 to 30, up to 32% body fat for women. And they were talking about how evolutionarily that made sense, right? Especially as, humans have a big brain compared to some other mammals that requires a lot of energy. So the fat storage made complete sense. So I just keep thinking about how little fat other mammals have compared to humans. The problem now is that we, as humans, now we tend to, we have plenty of processed food, so we tend to gain weight and have too much percent body fat. But I thought that was kind of interesting.
No, that is. And it calls into question too, if you think 1,000 years ago, what did our ancestors do? How did they get their food? How many days sometimes would they go between eatings? It's just very different than the energy intake options we have today versus you think about your feral dogs or the big cats. I mean, these are carnivores that were constantly looking for food, right? And it's a different way to survive than these other species have had. So it's super interesting.
Yeah.
Cool. All right. What questions do you all have that have come up that we should dive into, menopause or otherwise? And you feel free to drop them in the chat and we'll get to those. In the meantime, Dr. Lynn, you went to the International Menopause Society meeting a couple months ago, right? And you told
Mm-hmm.
us a little bit about that last time. So if you haven't had a chance to go back and listen to the last meeting, I'd highly encourage you to do that. But as you've continued to think about that and apply things in your practice, Dr. Lynn, has anything come up for you that's been, gosh,
Yeah.
I wish I'd said something about that because this was such a good one.
So there were two. So actually, I went to the meeting, but then about, I don't know, a couple weeks ago, they dropped the lectures so you could rewatch them.
Mm.
And also being that I was in Melbourne, Australia, I didn't go to every lecture. I went and enjoyed myself in Australia, so I got to listen. And there were two really awesome lectures that stuck with me. So one was on progestogens, which it's not progesterone. So progesterone is the bioidentical form, like we can replace progesterone. It's the same chemical structure as your own ovaries make. But there are a whole bunch of synthetic progestogens that don't exist in nature, but that we put in birth control pills, that we put in some of the older forms of hormone replacement therapy. And this lecture really hit home with me about why would we ever choose a progestogen? And so a couple things that hit home for me was are very proliferative in the breast, right? So we know that progesterone, depending on what study you look at, is likely neutral in the breast. It's not going to increase, it's not going to decrease your risk of breast cancer. But progestogens, so these are things like norethindrone, Provera, things like that, are very proliferative in the breast and have been associated with the small, but it's there, increased risk for breast cancer. So that's one thing about progestogens. The second thing that hit home for me, progestogens worsen insulin resistance. And I knew that somewhere in the back of my head because honestly, I looked back on my Instagram and I had posted about it. So I guess I had just forgotten about it. So when I rewatched this lecture, I'm like, yeah, progestogens are bad for your weight. I mean, we sort of know that like Depo-Provera causes a whole bunch of weight gain. And then they're not good for your lipid profile either. So you might say, why would anybody be on a progestogen over progesterone? And there is one good reason. They have a better bleeding profile. So they suppress the growth of the endometrium better than progesterone. But really, in my mind, as I sat there and listened to that lecture, I was like, why would we ever choose Provera? Why would we ever choose norethindrone? And so I pretty much almost always choose progesterone or Duavi, and then I don't want to hog the time, so I'll shut up here in a minute. Duavi is a hormone replacement therapy that does not have a progestin or progesterone in it. It has beta-doxyphene, which is a blocker in the uterus and a blocker in the breast and has great bleeding profile. So like when I have people on estradiol and progesterone and they're having irregular bleeding because that's a risk you run with hormone therapy, I'll often switch them to Duavi over using a synthetic progestogen like Provera or norethindrone. So yeah, that was a huge take-home message, and I'm really glad that I listened to the lecture again.
That's cool. I'm glad you shared that. And it looks like we have a couple of our colleagues in the audience who've asked some questions here. And so I'm going to read this and then we can all kind of give our perspectives. The first one is, could you go over how you would approach perimenopausal patients? In residency, it was more toward oral contraceptives, antidepressants, gabapentin, etc. Do you want to take that one first, Dr. Lynn, or do you want to go first, Dr. McKean?
Yeah, well, okay, let me just start real quick. Let's talk. So yes, so a lot of times women are in the perimenopause and they come in with symptoms, hot flashes, night sweats, and they're automatically given oral contraceptives. Or if they come in with anxiety, depression because of hormonal mood swings, they end up with an antidepressant, which by the way, the SSRI group, so Paxil, Prozac, Zoloft, lower your libido and can cause weight gain and make it harder to reach orgasm. So for me, when I look at perimenopause, that's a time where orgasm is already getting difficult to reach, where weight gain is already happening. So I'm really, unless that's not my first choice, the antidepressant. So it kind of drives me crazy when people come with perimenopausal symptoms and they get put on an antidepressant. So when I see my perimenopausal patients, you can choose an OCP, right? Especially if they need contraception or if their periods are really irregular. Hormone therapy will not regulate your cycle, and irregular periods show up in your 40s before your period stops. So an oral contraceptive or an oral contraceptive ring, I love the rings, they're really good, is an option. But if you have regular cycles and you don't need contraception and you're just having terrible hot flashes, you can use hormone therapy. So there's no rule that, oh, well, we're going to give you Paxil for hot flashes. In my opinion, that's just dumb, right? Like, why not give you the estrogen back? Because that's what you're missing. So when it comes to my patients, I'll usually give you, here are several options. Here are the risks, benefits, and side effects of your options. And then you can choose what works best for you.
Cool. And I'm going to come back to you in a second on some follow-up questions toward hormones, but I want to make sure we also address antidepressants and gabapentin, because I bet, Dr. McKean, you're seeing this in your practice too.
For sure. I mean, the folks that have been seeing me for a long time, I mean, they're going to probably start talking about it with me, or honestly, and again, another reason why we started these monthly conversations was because a lot of them go to their gynecologists and they are also started on antidepressants versus hormones because they're still, and again, I'll swing it back to Dr. Lynn here shortly on like kind of going through those iterations of safety. And I think that's going to be asked in some of the other questions. And I always let my patients know, like, I'm, trying to get myself back up to speed on some of these things, but I'm certainly not the best person to be asking through all the risks and benefits of the different kinds of hormones. But yeah, I tell them if most of this showed up or got exacerbated when you got in perimenopause, like if we've had your anxiety and mood stable on whatever regimen you're on, because most of my folks, frankly, like are probably already taking something for mood or anxiety. So this is more like new things that have shown up with perimenopause. And I'm like, well, the only thing that's changed is now you are like in that age range. It's following suit with, what your mom or your older sibling, older sister like went through. And maybe you are having irregular periods or hot flashes. But I also reinforce to my folks, like, because they're told, like, well, your periods are still regular, you're not having hot flashes, you're not perimenopausal. And I'm like, that's not necessarily true. Yes, those are common sorts of presentations, but they're not the only thing. So I usually do encourage them to like have those conversations with their gyne first, because I'm like, yeah, I mean, if we change what you're on, if we adjust it, that may help a little bit. But just like with premenstrual dysphoric disorder, which is another situation where I'm often referring them to have a conversation with their gynecologist about hormone treatment, is if it's related to cycles, if it seems to be hormonally driven, then my medicines are just kind of like a not very effective bandage on that. But the converse is also true. Like if somebody is developing symptoms that seem like more than just related to perimenopause, then that's where they could benefit from both. And then, yes, we go through and pick the ones that would have the least impact on weight, the least impact on sexual side effects. And I kind of go through with them and like continuum, like which ones are the most notorious and probably like non-compatible with everything they're going through, and which ones can be the most helpful.
Yeah, and sometimes you need that multiple perspective to give individuals the best assessment and plan. Um, I think there is a lot of confusion. So certainly there's individuals who can't for whatever reason or won't take hormones, right? So I'm not addressing that with this next question. But when it comes to the individual who is on hormones, and we have a question specifically around progesterone and testosterone, symptoms would benefit from estrogen, but she's had bleeding in the past. Where does that come into your conversation with information and education and counseling? And when do you say, hey, you've had enough bleeding on this that we need to start doing ultrasound or an endometrial biopsy? Do you want to address any of that, Dr. Lynn?
Sure. So when I start people on hormones, you can have some irregular bleeding when you start hormones. So if they weren't having irregular bleeding before and then you start them on hormones in the first 3 to 4 months, I'm okay with that. If after that they continue to have irregular bleeding, then my like ears perk up a little bit, because you don't want to miss anything. You can't blame everything on hormones. And so if they continue to have irregular bleeding, or if something's changing and maybe now they're bleeding much more heavily, I will do an ultrasound and an endometrial biopsy. I usually start with the I mean, it depends on the situation. Sometimes I order them both, do the endometrial biopsy in the office. Sometimes I just do the ultrasound. It really depends on the story. Everyone's story is slightly different, but it is important because you don't want to miss anything. It's important to do an exam too. So I think, in medicine, a lot of times the exam is becoming a lost art because, we just order an ultrasound, but you got to look in the vagina, because not all bleeding is due to hormones. You got to look for, is there, a endocervical polyp in the vagina? Do they have an infection that can cause irregular bleeding? So the differential diagnosis for irregular bleeding is big. So and you need to rule out pregnancy also. Like there's just so much you have to think of. So if like no irregular bleeding, you started them on hormones, whether that's a birth control pill or hormone therapy, and then they have bleeding and for the next couple months, like leave it alone. But if it's persistent, you have to figure it out.
So every woman who's 45 and older just like gasped when you said think about pregnancy because they're
I
so
know,
mortified about
I
that
know,
possibility.
but it can
You're right.
happen.
Well,
I
and
know.
isn't it, tell me if I'm wrong, but the second high group of unplanned pregnancy, the second highest group behind teenagers is women in their 40s with an unplanned
Yep,
pregnancy.
because they
So
think, I'm too old. It won't happen to me.
yeah, so
So yeah, you always have to rule out a pregnancy. And let me tell you, when I see patients, sometimes I'm like, well, we'll just get a pregnancy test. And every time that jaw just drops
yes,
and I see
they're
deer in
horrified.
headlights. And like honestly, I can't even tell you the last time any of those was positive,
Yeah,
but at least now we know
right.
we're not pregnant. We're not missing that. So it's really important to know.
Absolutely. And I think I'm gonna go back to this initial question about how do you approach perinatal patients, and we all do it differently. In my practice, we actually put them through the NAMS questionnaire. So North American Menopause Society, as Dr. Lynn said, has now become the Menopause Society. It's the same form, and there's a specific page on it that asks them, I don't know, what is it, 50 different questions that they could be having, because there's more recognition that it's not just hot flashes anymore. And this leads into the next question we have, which is the idea of pre and post menopause. There's this idea of chronic pain. Is this fibromyalgia? And how do we deal with the musculoskeletal complaints for women, especially when it comes to chronic pain? Knowing that as we get older and our bodies are wearing out, we're going to have more pain from just osteoarthritis. But fibromyalgia, I'm super curious what you think about this, Dr. McKean, because when I was training, if we go back 15 years ago, fibromyalgia almost seemed like a woo-woo diagnosis, and nobody was thought that it was real. I know that still exists today for many colleagues, but whether they believe it or not, there's people who are living this, right? So through the lens of somebody who's living with this chronic pain and it's been called fibromyalgia, how does that come through from your lens? And I'll address it from the musculoskeletal in a second, but I'm curious, what do you think on that?
Well, I agree with you. When I was in training, it was always considered to be a diagnosis of exclusion. And if people had it, they weren't being taken seriously. I think, at least I've personally seen a shift with that over the last several years, where it is become more of a firm diagnosis. It's become something that like isn't considered, quote, all in my head sort of thing. And people are actually being appropriately managed and treated with it. But I think it's just like a lot of other things. It just needed more time to have more therapies, because it isn't a, oh, this medicine for this. It is another one of those like multifactorial, multidisciplinary approaches, and like a lot of other chronic issues. So it can be chronic pain for other reasons, but I have to have those conversations, because yes, somebody's going to come into my office with depressive symptoms, anxious symptoms, sleep issues, what have you. And if it's exacerbated by their chronic health condition, which is chronic pain of some kind, it is talking with them about, okay, if they've told you that like remission of symptoms is not going to be what's going to happen, if that's not going to be necessarily the goal, like it's learning to live with that. So a lot of times it's on my end choosing pharmacotherapy that can be complementary to whatever other physical therapy, occupational therapy, massage, acupuncture, or actual pain medications that they might be being prescribed. So I lean more on the antidepressants that are also known to help with pain if we're needing to treat, so don't have like multiple things stacking on each other. Because I'll find that like I'll prescribe something and then they go to somebody else and they prescribe something. And then now all of a sudden we've got like 4 or 5 different things that are all trying to treat the same thing, and then stacking on that a lot of side effects. So I look towards like duloxetine, which actually is FDA approved to also treat fibromyalgia and neuropathic type pain. Gabapentin has its uses sometimes on the psychiatry side of things. Most of the time I see just sedation and like dullness and blunting of affect, and that isn't necessarily the best. But that's on my lens of it. I always say, like, if there's something that I can do that can be complementary to what others are doing, then let's do that. If it's sleep issues with pain, amitriptyline, sometimes at low doses can still be, a lot of the old school stuff that other people don't think about anymore can still have a lot of utility in these kinds of folks.
Mhm. Yeah, very, very well said. And I like how you pointed out the stacking of meds, because we don't always, we may look at it through the narrow lens of what we prescribe, right? We might acknowledge that, oh, other meds can have side effects, but they really do cumulatively impact people. One thing that I've probably in the last year started really offering to my patients, and I will easily tell you that there's a lot of debate in this next area, but for the purposes of a broad discussion, there is some things in functional medicine that are interesting on this, things that are looking for toxins, this idea of being detoxed. Now, I have a hard time in the first world country we live in ascribing that parasites are everywhere. We have colleagues who say that, right? So I haven't gotten to the point that I can go down that road, but I do see a
Either.
number of people who can detox from alcohol, from sugar, from chronic stressors, even if their cortisol is normal, it may be high for their baseline for their body, which we don't have a way on a test to capture. So I think there's some interesting ideas there that people resonate with, and they feel like it makes a ton of sense to them. not too long ago in the news, we were reading that we have a plastic problem, right? That we're ingesting so much plastic that it's like a credit card size amount of plastic in our body. So if that's true, then we can't totally rule out the possibility that there's other things negatively impacting us. So I'm curious from that perspective if you've heard anything in your respective fields, but I think this idea of toxicities is growing, and I hear it from a number of people that I'm caring for that they're interested in knowing more and whatnot.
Yeah, I definitely think there are toxins in our environment, and the problem is that I struggle with is how can you avoid every toxin? And there's a lot of toxins out there we don't know about, we can't test for.
Mhm.
So, I struggle out. And in fact, there was just an article that the Obesity Medicine Association put out about obesogens, which are toxins in the environment or endocrine disruptors that lead to weight gain. And I read it, and there are all these chemicals. I don't even know where they exist. Like, how can
Yeah.
I avoid such and such a chemical if I don't even know where it's found?
Mhm.
So I thought that was an interesting article. So if you're on the
Yeah.
ABOM and you have to do the board review, it's an article in there. So yeah, I think it's tough. And then one other thing, I just want to go back to the fibromyalgia thing and the joint issue, and then we'll leave that alone. I see this all the time, joint aches. And I have heard, I agree that like when I was studying, fibromyalgia was sort of woo-woo. But I believe in fibromyalgia and chronic pain. And I believe that people with fibromyalgia hear pain louder in their head. And it's very depressing, right? If you didn't have depression before and now you have it, I mean, now you have fibromyalgia, who wouldn't be depressed?
Yeah. Right.
But I also wonder, there's more recognition of perimenopausal symptoms besides hot flashes and night sweats. So things like joint aches. And so I wonder sometimes when women would come in and talk to their doctors who just weren't really aware of perimenopause, and they're like, everything hurts. My back hurts. My fingers hurt. Everything hurts. I'm moody. I'm anxious. I'm depressed. I wonder how many of those women just got the label of fibromyalgia when it
Mhm.
was just the perimenopause. So
Yeah.
I wonder about that. And it's true, like not all joint pains are perimenopause. Aging, osteoarthritis, rheumatoid arthritis, it can be so
Yeah.
many things. But I just wanted to throw that out there with the fibromyalgia thing.
I'm actually really glad you brought that up because I don't think, for our non-medical listeners here, I don't think people recognize that there's this huge spike in midlife women for autoimmune diseases that affect the joints. It's not
Yes.
all rheumatoid arthritis. There's other ones as well, psoriatic arthritis, which by itself increases risks of stroke and heart disease like rheumatoid arthritis. You've got lupus. And you've got all the GI diseases that are associated with arthritis now. And so the frustrating thing as someone who's trying to make a diagnosis is I don't have tests for all of those, right? I don't have a test I can do to say you have psoriatic arthritis. I have to put it together clinically to the best we can. Well, lo and behold, that might match the symptoms of perimenopause, or it might match the symptoms of something else. And so, to your point, I think people are getting missed. And I do think there's a lot we have overcalled that had to do strictly with needing to get a diagnosis on paper so that we could end that encounter and get paid for it by insurance, which raises a lot of bias questions about what are people being diagnosed with that they do or don't have, and people can't get that out of their charts then. So you raise an excellent point that I wonder too, and I don't know that we'll ever know that, right? But people being able to advocate for themselves and getting second opinions and saying this doesn't make sense.
Yep.
Uh,
Second opinions are good.
yeah.
Two heads are better than one.
Always. Yeah, I mean, I had somebody ask me this morning too, can I get a second opinion or will that offend my doctor? And I found myself sitting there thinking, if that offends your doctor, you're not at the right doctor. Like
Yep.
that should never be something that is found to be offensive. Um, so
Definitely agree. Because what if they think of something I hadn't thought of? And
absolutely.
that's wonderful.
Or maybe they think it is the same thing and it just validates to your patient that they're on the right track, independent of what I told them, right?
Right.
So I think those are quite valuable. I think we made it through all the questions. So if there's other questions from our audience, throw those in the chat. If we didn't ask your question the right way, I was doing my best to go through these, but if we didn't catch your question the right way, please jot that in the chat as well so we can follow up on it. One question that I have, I guess this is more for you, Dr. Lynn. I recognize that testosterone therapy in women is becoming increasingly accepted, that there's more, especially gels for it now. I'm just really leery on all the compounding that's happening. And so walk me through your thought process. How can I, as somebody who's taking care of these women, how can I become more comfortable with that, more confident that they're getting the right amount, the right time, that it's not something
Yeah.
that's going to harm them?
So it's interesting you should ask me because
You want me to ask Dr. McKean? Come
no,
on now.
no, it's good. It's good. So, like, when I started doing this, I always used compounded testosterone. And a couple years ago, ISWISH, the International Society for the Study of Women's Sexual Health, and the Menopause Society did a consensus paper, a white paper, looking at testosterone use in women, looking at all the research, the evidence. Should we be doing it? Who should we be doing it for? What do we have to worry about? And they came out and said that you should avoid compounding testosterone because compounding pharmacies, they've done studies that between batches, you might get a different amount, and pharmacy to pharmacy, you might get a different amount. So when this paper came out, I'm like, great, I'm going to switch. They recommended, the experts, right, who looked at the data, recommended using a product for men like Testim. So I switch all my patients to Testim. And in the papers, like I've read the papers, it says do 4 drops to your inner thigh. So I switched my patients and oh my God, it was a disaster. It was not a disaster, but like to dose, how big is a drop, right? Like how big is a drop? And then they would squeeze the tube and all the testosterone would come out and the tubes would come in a box of 30 and the pharmacy would not sell you 1 tube. And insurance never covers testosterone because it's not FDA approved for women. And so nobody would break that tube and it would be like $500 to use a male product. So I'm like, this is not working. I'm not going to follow these big guidelines. I'm going to continue to do the compounding. And I did. And I always follow the levels to make sure it doesn't get too high. But lately, there's been a lot of discussion in my circles about using the gel and putting it in a syringe, right? And then if you use the Testim 1%, it's a half of a cc or half of a milliliter. So you can actually dose it in that syringe. And with GoodRx now, there's a generic Testim, it's cheap. So now I'm sort of going back to that for that reason. And I have recently had patients who I have them on a standard dose of testosterone and their levels came back unusually high. And part of me wonders, does that have to do with the compounding, right? Because it's not regulated like a regular product. And for the majority of my career, I didn't have that issue, but lately I've seen some like little higher levels and who knows what's that from. So long story short, I'm going to start switching everybody back to a male product. Oh, I think you're on mute.
You got to keep us posted as you do it, okay?
Okay. Yep.
I really resonate with the next question that came in because what I find in my internal medicine practice is, it's one thing if I'm treating a man with testosterone, there's very clear guidelines of when do you check it, what should the ranges be, what is the high, what is the low, what's acceptable, etc. And what else should you monitor, like a CBC and a PSA, right? In women, I don't find that there's that clear consensus at all when it comes to checking. So I'm curious, when you are checking levels, are you checking it before their next dose that's supposed to be administered? Are you checking it after they've done it for 2 or 4 weeks, or how are you doing that?
Yeah, I'll usually check it like 3 to 6 weeks after starting, but it's not like a shot, right? Because if you give a shot, and I rarely ever do an injection, you get a whopper dose and then it gets metabolized over the next 2 weeks or so. And then you get another dose. So for when you're doing shots, like when I do transgender medicine, you want to check it like right in between, not right at the time you get the shot or right before the next one. You want to find sort of that middle ground. But for women, I do it daily. So they reach a steady state of testosterone. So no, it doesn't have to be morning, night, in the middle, I just have them check it.
Gotcha. And like in men, when I'm diagnosing hypogonadism, to say you need testosterone, right? I'm doing the 3 different early measurements, and then I check their LH and their FSH, the brain hormones. We're not doing any of that in women. I mean, are you doing that? Because I'm not doing
Not
that.
LH and FSH.
Yeah.
No. I do check a baseline. So that is part of the recommendations. I will check
total and a free.
baseline testosterone, just total.
Okay.
So free is not really accurate in women. Like the machines that we use to measure testosterone in women are actually much less accurate because they're designed for much higher levels.
Mm.
So it is recommended to use total testosterone and not free. And also sometimes free is calculated. So
Not helpful.
I always go with total testosterone. The recommendations do recommend that you check SHBG, sex
Mhm.
hormone binding globulin. I don't always do that, but if someone is not responding to testosterone, I've been doing it more lately.
Yeah.
But if they're not responding to testosterone, I'll check their SHBG. And if it's really high, when it's high, it binds to testosterone, so there's less available free. So I might feel more comfortable raising their total T a little bit higher if
Mhm.
they have a high sex hormone binding globulin. The other thing that the paper recommends you check are LFTs, which
Mhm.
is always kind of, for me, I'm kind of like, why? Because when you do topical, you avoid the first pass effect.
Right.
Now, if you do oral testosterone, which I never do,
Mhm.
because it can negatively affect your lipid profile, then it makes sense to follow your LFTs, but it's in there. So usually I'll just get it once, like a
Mhm.
CMP.
Super interesting. And I have, for better or worse, had to be reading more on testosterone in men recently. And so there's a lot of things that in my head, I'm like, well, of course, women were excluded from this study. So what would it translate to women? But one of the things that we're seeing in men's health is that if you will treat diabetes or prediabetes, if you'll treat those individuals with testosterone, you can reverse or normalize their glucose. We don't have that equivalent study for women, but I
Yeah,
am, in these individuals, like the lady I talked about at the beginning, she's got the labs that are looking okay. She's got the belly, can't quite. I mean, there's a part of me that's like, do we go down the GLP road, or do we see if for 3 months you do a little bit better with testosterone? Because we just
yeah.
don't have the good research for it. But
We
to your
don't, but
point, it's not a
yeah.
weight loss med.
There are people working on that, but there's not enough data right now. But I've heard that about men, about
Hmm.
diabetes and
Yeah,
testosterone. We don't
yeah,
have that same data. But I feel like after I went to the International Menopause Society, I feel like within the next 10 years, we're going to have so much more info
yeah,
just from the studies that I heard that were ongoing about things
absolutely.
besides sex drive and
Yeah.
testosterone in women. Because we don't even have I've had patients come to me and they're like, I need to be on testosterone for my bones.
Hmm.
And I'm like, well, we have all the data to show that estrogen helps your bones. But
Hmm.
when you look at the data for women, it's not there. It's all in
Yeah.
men and how
Uh-huh.
testosterone helps your bones. So maybe in the future, we'll have data on women. But for now, we know estrogen can help preserve bone density.
Yeah. Hormones are not poison. They're not perfect. They're not for everyone, but they're certainly a good tool in the tool
Yeah. I
belt.
mean, everything has risks, benefits, and side effects, even natural things. I always say natural is not always better. Cocaine is natural for you. Definitely not.
Let's please not
So
do that.
yeah, even supplements have risks,
Mhm.
benefits, and side
Yeah.
effects. So it's important that get good information so you can make a choice. Are the benefits worth the risk?
And you kind of alluded to this already on the compounded hormones, but just to pull that out a little further, that applies to the compounded GLPs too. And I'm seeing a number of people who really truly believe they're taking the same thing, and it's not at all the same thing chemically. Are you seeing any side effects yet from that in your population? Are you running into any complications of those yet?
I don't do any compounded GLPs
Mhm.
because the FDA has come out and said, don't do it.
Yep.
We really don't know. And I'm very fearful of these oh, I'm going to order it on the internet from who knows where, who knows what's in it. It's not
Yeah.
regulated.
Yeah.
So I have done no compounded well, that's not true. I have maybe one or two patients on compounded, but I try very, 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 very hard not to do it if possible. The struggle is cost.
Hmm.
Insurance does everything they can to not pay for it. There are some ways to get it cheaper. Like I will choose Ozempic from Canada over compounding because it's really Ozempic.
Hmm.
And then there's now Lilly Direct for
Yeah.
patients where you can order directly from the drug company and it's cheaper for the lowest dose of Zepbound.
Hmm.
And sometimes I'll space out the interval between the GLPs for patients who pay cash. It wasn't studied that way. That's not how it's
Hmm.
meant to be prescribed, but it works. And I'd rather do that to lower the cost than to do compounded because I just feel like there's danger on the internet. All these places trying to sell you weight loss drugs scares me.
Hmm. Well, and just
And
again to the audience. What's that?
even like the corner med spa selling you
Yeah.
compounded, that makes me nervous.
So some of these compounding places have reached out to me as a business owner and said, we want to, and I've really asked them, where are you getting this from? How are you doing it? And they'll swear up and down that it's all legit, but they won't tell you either. And if someone's not going to tell me where they're sourcing their product from, I'm not very comfortable prescribing that to my patients.
Yeah.
I do like the idea of the every other week. If you're paying out of pocket for it and treating, injecting every other week because of that long half-life, I do think people can get some benefit from that. And I think that even though it's only the lower doses that Lily Direct does, that's still something. And so
Mhm.
I don't have a problem with people doing that. I've never done the compounded GLPs because I cannot convince myself scientifically. And you said it really well. It's that this stuff isn't the same batch to batch at the same pharmacy, and it's not batch to batch the same at different pharmacies. So if we can't say what that quality measure is, why do I want that in my body? And that's true of supplements too, right? And so if you're going to go down that road, knowing that something's been third party externally tested for quality means a lot to me if I'm going to take something that's not FDA approved. But
Yeah.
so interesting. Dr. McKean, what have we not thought about? What's our blind spot on here that we need to go into?
I don't think we've had any from today. I just think on my end, because again, I have a lot of people that see me regularly and are apprehensive about hormones or apprehensive about going to see like yet another doctor about something. I think, for me, they're always asking me like, you know, what is like the safest thing to do? And granted, it's like there isn't a best antidepressant sort of thing, but they kind of want to know what the absolutes are because there's still a lot of incorrect information out there about like who can take hormone therapy, who can't. So I think some of those like straightforward things, whether we do that this time or next time. But I've talked to them a lot about like vaginal estrogen and how like that really there isn't any contraindications to overall. Like, that's something that can be really helpful with helping to that is getting a lot of like press to like have certain warnings and stuff removed from it because it is being said to increase like all of these like horrific things. And really it's not since it's a more local sort of thing. But I just think in general, like a lot of people are like, well, I didn't do well on birth control pills. I don't think I can take hormone therapy, or like I heard that maybe I can't take it because of this. And they get frustrated because it is figuring out who can they go to get actual information and not feel that they're being dismissed. And I'm
Mhm,
trying to like let them know that, if that happens, it's because honestly someone's just not comfortable. Like they aren't paying attention. They aren't
mhm,
interested and invested. And it is okay, just like getting a second opinion. But I literally tell them like, the OB-GYN that you were seeing to for all your obstetrical care might not be the same one that you now are going to see in your 40s and 50s for
mhm,
this time of your life. Like it's impossible. Again, it's impossible to know everything. It's impossible to be good at everything. But what I'm finding is they're not having people tell them like, oh, I'm not up to speed on that. They're just being told like, oh, that's just you're not in menopause yet, or
mhm.
and versus being willing to say like, hey, that's not my interest and not my forte. My colleague so and so though, like
Yeah,
might be a good gynecologist for you to see for this phase of your life.
that's really well put. And it made me think of a patient, Dr. Lynn, I had over the summer who was on hormone therapy, was doing beautifully with it. Um, had a TIA versus
Mm.
concussive symptoms. It was really unclear. Got to the point that we actually had neurology weigh in, and neurology is like, yes, she can use hormones. But I still felt queasy about it because there's just so much that was drilled into us that if someone's had a stroke or a TIA, they can never take hormones. And
Yeah.
yeah, I think I may have actually sent her to you and said, get a second opinion.
Yeah.
Let's just play this out a little bit more because there's a reason those guidelines exist, right?
Mhm.
Um,
I've
so do you
definitely
have
run
any
into
thoughts on
that
that?
where people, they don't know, right? Like
Hmm.
we can't
Yeah.
say, was it a TIA for sure or
Yeah.
was it not? And
Right.
I do find those really challenging
Hmm.
because we just don't know. So we just
Right.
have to look at the big picture. Is it worth taking a possible risk or not?
Hmm.
That's a tough
Right.
one.
Super tough. And, that's where I think we have to sometimes just ask for a lot of grace and ask each other and pull each
Mhm.
other in because it is tough. especially when they're doing so well on it. It's one thing if somebody wasn't doing well, and it could be like, well, we still don't know, but we'll take you off of it. These others are tricky. So
Yeah.
super good conversation as always, ladies. Wow. We went through a lot today. I don't know if that's where you thought we were going to go when we jumped on the phone.
Yeah.
but
Yeah.
You
I
never
do
know.
have one
yeah,
little, little advertisement, just
do
so
it.
anybody's interested. Here at Evora, we just hired a pediatric obesity specialist. Her name is Dr. Trito, and she treats kids and teens who are overweight, or have obesity. And I'm super, super excited. She's fellowship trained in pediatric obesity. So I just wanted to throw that out there. If anybody's interested, they can call the number that I put in the chat. But I just feel very grateful that we can help kids, because
Yeah.
even though I had to study pediatric obesity to get board certified, I do not treat kids, and I'm not the right doctor for that. So I'm really excited that she joined us.
Oh, that's great. Congratulations.
It's awesome.
Thanks.
The more you can be collaborative and inter-specialty collaborative in the same building makes it easier for everyone. So that's
For sure.
fantastic news. I think each of us dropped our contact info in the chat. Dr. McKean, remind us, when's our next meeting? It's January 8th?
January 8th, because we tend to do the first Wednesday of the month, but that's New Year's Day. And we felt like
We will not be
for
here.
us and for you all, that probably wouldn't be an opportune
We will
day.
not.
I'm as the mental health specialist here, I would advocate for like rest and reflection on that day versus listening to us. But January 8th at 1 p.m. So
No,
if
no,
we
at
do the
noon. At
same,
noon.
oh, that's right. It's gonna be
It'll
noon.
be
Sorry,
at noon on the 8th. Yeah.
noon on the 8th.
And
And
then
then we'll
it'll
get
go
back into
back to
our
the first Wednesday at
yeah.
1.
Yeah, so the 8th at noon, it'll be the same Zoom link, but we will all put out, something on our respective social media pages that week ahead of time, with reminders. All
So
right.
if you're
well,
not following us on social, please do that so that we
you.
can get the information to you.
Yep.
Ladies, great seeing you again. Have a wonderful month until we reconnect and see each other in 25.
Okay, take care.
See
Bye.
ya. Bye.